Thank you, Suma, and feel very honored to be part of this IC. Just that is enough to put pressure on you. You know, now you say, what should I have to do a little Bharatanatyam? How do I?
At the end of the session, we'll have a song from you. She sings beautifully. She's the nightingale of our pediatric ophthalmology department.
Thank you. You're too kind.
The
Thank you. So I'm going to tell you a little bit about. No, I want the lights on. I want to see my audience. They have to see my dancing. So what? So we're going to talk a little bit. Everybody here, are you all comfortable asking and looking at the MRI when a child comes, a special kid comes? Yes? How many of you? Yes. Yes. All right. Now I'm just going to talk very briefly about what kind of changes we see in such patients and really what is the future. There are some very exciting new types of imaging that are coming which are really going to tell us a lot more than even the conventional MRI. So we're going to talk about these things briefly. Where is the light switch? In the main hall, is it? Hall A. Anyway, so brain imaging can accurately define important parameters regarding the nature of the cerebral injury, such as the location and the extent. So there is a possibility of identifying characteristic features that may have prognostic value regarding neurodevelopmental outcome. In other words, if you look at the MRI and you see X, Y, Z, then you know this child is going to have this kind of problem, this child is probably going to improve. That is the kind of inference and correlation you can have when you look at the MRI. So if you broadly classify them as preterm and term, right? So preterm is where you will see periventricular leukomalacia. In those patients, the MRI findings, the severity and the extent correlate quite well with the neurodevelopmental findings. Whereas term children with hypoxic ischemic encephalopathy, the other type, the correlation is not always consistent. Okay, remember that PVL is much more consistent. So that is a typical, the one on the left is actually a CT scan. And as is not uncommon in our country, we still have patients coming with a CT scan and not having the financial resources to get an MRI. So sometimes you'll just have to make do with it, with this. And you can see there is severe encephalomalacia. Okay, so sometimes this is enough. That is correlated on the MRI as well as what encephalomalacia looks like, very common in HIE. Okay, you can also see thalamic injury in HIE patients. But periventricular leukomalacia, I guess everybody is familiar. You can see the whitish changes around the tips of the horns of the ventricles, and those are very typical of preterm infants, and these are very sensitive. You will only see them on the MRI. So if you have a child who is not doing so well, a preterm child, functional vision assessment tells you this child is having several problems, encourage the family to get an MRI and look for PVL. Sometimes they will come with strange complaints from the school. Child is having problems playing with the other kids, socializing, but seems to be doing okay academically. The child may be having field defects, may be having problems localizing, identifying face because of poor contrast. And nobody would have thought of getting a neuroimaging. In such patients, especially if there is a preterm history, go ahead and get an MRI and look for periventricular leukomalacia. Then it opens up a new chapter. It says, oh, okay, I am dealing with PVL and now I know what the child is going through. And then you can say, this is how I am going to help the kid. So severity of PVL correlates with neurodevelopmental outcomes. Mild PVL, minor motor problems and mild functional impairment, cortical atrophy and thinning of the corpus callosum if you find, and we'll see an example of that, likely to have much more developmental delay. So there you see there is a clear thinning of the corpus callosum where the arrows are pointing. Normally it's a nice, robust, big arc. Another study said that when they looked at acuity, visual field, and poor performance in optokinetic nystagmus, it correlated with damage to the optic radiations. So MRI is good and is the best Ultrasound of the cranium and CT scan really are not very informative. But if you look at it, the underlying microarchitecture of the key white matter pathways, such as optic radiations and cortical connections, cannot be fully ascertained even with the standard MRI techniques. So what do we have next? So what we have next is the diffusion MRI technique. Now, there are many places, metros, big radiology units, which offer it already. But this is the future. If we are going to manage CVI children, we need to have access to diffusion MRI techniques. So diffusion tensor imaging, DTI, and high angular resolution diffusion-based imaging called HARDI. So DTI and HARDI combined with tractography, which means the actual nerves, the actual tracks are mapped out. Analysis techniques, these are the future. So they reveal the organization and integrity of specific white matter projections. So how does it really work? The diffusion MRI tracks the movement of water molecules in the brain. The constrained motion of water in association with the orientation of the axonal fibers allows for the overall organization of the white matter projections to be inferred. So it's almost like you're virtually dissecting the brain and are able to see the tracks. So let's look at some examples. So this is an example of a HARDI. It's kind of a smaller picture, but the one on the extreme left is the control, is the normal patient. You can see in the PVL where the arrow points, there are already less tracks, there are already less fibers. So PVL, the tractography is much more sensitive. In the other, which is the non-PVL HIE injury, there are areas, let me point to this, there are areas where you see the tracks are missing, but overall there is not much variation between the two. Okay, so this is what a tractography looks like. So let's move on to a few other things. This is a specific visual field defects are present. Usually it means radiation, optic radiation damage, and that is how the optic radiations are mapped. Okay. Now, a couple of more slides talking about what we already heard, dorsal stream dysfunction, which is the where, which is spatial visual processing. Okay, where. And if you see that, and that has been localized to the superior longitudinal fasciculus. So if you remember anything from this talk, you remember SLF and ILF. So the superior longitudinal fasciculus, when it's damaged, it causes spatial visual processing problems. So if you look at the PVL patient, you can see vis-a-vis a control, you can see the red area, which is the most sensitive tracks in the middle of the SLF are all damaged. You can see it in the axial, the sagittal, and the coronal views. You can see comparing the control versus the PVL. So what about the ventral stream dysfunction, which is the what? Which is in the temporal lobe. So this is the object identification and recognition, which is inferior longitudinal fasciculus, and you can see exactly where the inferior longitudinal fasciculus is going, and there is the tractography of the same. So this is an example of a patient where you can see the A is the normal, and B is a patient who has got visuospatial processing problems. Look at how the SLF, the superior longitudinal fasciculus, is completely thinned out, whereas the inferior longitudinal fasciculus looks almost normal. In the last picture is a patient where has both dorsal stream and ventral stream dysfunction. You find both the superior longitudinal fasciculus and the inferior longitudinal fasciculus tractography shows completely thinned out, right? So that is the future. The future is not just looking at the MRI, but asking for DTI and HARDI and tractography analysis, which is going to be what we are going to be looking at in the next many years. That's all for this talk, and I'll move on to the next one. है और इसी में है एक, हाँ. So this talk was originally going to be given by our CVI special clinics head, Dr. Rizwana. But she was unable to come, so I am going to try and do it. So I'll say a prayer that the videos will work. So we're going to talk over the next few minutes about functional vision assessment and CVI grading, because really for our own satisfaction, for parents and for the overall science, we need to see whether our interventions, we need to quantify them and grade them in some way to see if they are really improving. So if you do not have a grading system, there is no, you'll be biased. You're already biased. You're the treating person. You want the patient to get better. The parents want to get the patient to get better. So you will imagine things are better. But so unless you put a grading system in place, give it a number, then that is the scientific way to do it. That's why we need to have a grading system. Okay? So why even do cognitive testing? It is concerned with how humans combine the information from the visual scene and their previous knowledge. So what are the scope of cognitive vision? First is visual attention, which is spatial attention, selective attention, visual search, control of eye movements, and etc. So what do you mean? You're trying to locate an object in space, right? For which you need to have both attention spatially, then you need to zero in on the object of interest, and then your eye movements need to correspond so that you locate the object accurately. You don't have an overshoot. Now, it also is important for short-term and long-term memory and object, face, and scene recognition, because you might zero in on this object, but you may still not recognize it. So all these components are important in the cognitive testing. So this is just a slide to shows you how all a child can react to a balloon. So it looks at it and follows it actively, now has turned over because the balloon has gone away, and now is trying to crawl towards it. Okay? So what is really functional vision? It is how the person uses vision to perform tasks of daily living in a dynamic environment. So if you look at Dr. Rath's talk, it was a lot about detailed testing of various aspects of visual function. But if you translate this to how really this is used in everyday life, that is what really functional vision is. There will be obviously some overlap between what you said and what I'm going to talk about. So how do you identify, interpret, understand, and interact with the object of interest and the world is really what the functional vision is testing. So the why functional vision? It's to identify the present level of visual performance. It's also to understand functional implications based on visual status, because you're going to be deciding, is this child going to go to a mainstream school? Is this child going to go to a special school? Even if the child goes to a mainstream school, is he or she going to have social interaction problems? Is he going to have problems with looking at the board because his field is limited, etc., etc. So they all have a lot of implications based on what your functional vision tells you. So what are the components? If you look at the components, is visual alertness to the environment, facial communication distance. Do you have to go really here for the child to be able to really see you and recognize you? Visual acuity, fields, contrast sensitivity, color preference, a lot of which was covered, eye movements, saccades and pursuits, latency and span of visual attention, cognitive vision test for respective tests, and visual perceptual skills. So we're talking about various, if you have to break functional vision down, you talk about imitating facial expression, like how the child reacts when he or she looks at themselves at the mirror. Sustain near vision task, which would means what you need in school is to copy. That is a sustained near vision task. How about daily care? Can they, do small things to take care of themselves? How about mobility? That inferior field effects are very important for mobility. And how about communication? So the recognizing the face is the first step towards communication. Now, visual field modifications are several ways can be tested. Some you already covered, which is the puppet face test, the Leia Van test, and you can also just substitute with interesting toys if you don't have access to have one toy of interest and bring the other toy from the extremes. Also introduced obstacles to see how the child's inferior visual field is working. The child is just kicking and sort of stamping on all the objects that you have thrown on the floor. Now this is a video, and it's just showing the test, how it works. So child with an inferior visual field defect. So she's actually following now. You attract her attention. And then the second object is brought. Only now she sees it. That's how profound her inferior visual field defect is. So that was a little better. Okay. Saccades and pursuits, which you already know. Its testing is similar to how you do it in adults. And then the layer puzzles, which teach a lot about orientation. So let's look at how the layer. So layer puzzle has one where there are colors. So the object that they have to put into the little shapes is both matched by color and by shape. But for a little more testing, you can offer only the shape in black and white. Okay, so let's look at how this is done. So there he's trying to figure out. Aha. So he's trying to match the color. Look at him. It takes him a few seconds. So now you challenge the child by changing the orientation. So he has to reorient before he fits it. Now if you see, he's having considerable difficulty because he doesn't have the color cue. Look at that. You would think that's simple. So this is the layer mailbox. Again, this is for a good way to know whether they know about orientation. Okay. So let's look at it. It's quite self-explanatory. So he has to insert that folded paper through the slot. So that went not too bad. Once more. Now he's starting to get the hang of it. Then now you've changed the orientation. If you see, he's still trying to keep it vertical. Aha, he did it finally. And this is a child with a normal vision, struggling with orientation. He finally got the hang of it. All right. So this is another layer rectangle where, again, they have to have a good concept of smaller to bigger or bigger to smaller. Okay. Let's see how this goes. You teach concepts of ascending and descending sizes. Both squares and rectangles. See, the challenge is, a lot of visual inattention also is there in these children. And that's quite a seasoned optometrist, actually. So she's telling him, again, there's a color cue and a size cue. Still struggling. We've made no progress, as you can see. So other smaller tests that sometimes you can create it yourself. This is an object sorting test, again based on color primarily with Lego blocks. So we'll move on to the idea of tests of visual perceptual skills. Now this is a standard comprehensive assessment of visual analysis and processing skills. If you have kids who are doing well academically but in certain areas seem to be struggling and you suspect that they have functional vision problems, this can be done, and that's sort of a sample chart where they're given different tasks to perform and then they're graded based on their performance. So I'm going to just go on to one of the case studies and let's look at the case in detail. So this is a 7-year-old male with complaints of squinting of the right eye since birth and also complaints of copying difficulty in classroom from the board, going to a normal school, in the lower kindergarten. No history of surgery or injury. There is delayed milestone, but not under any therapy. Birth history is full term, and maybe a borderline low birth weight of 1.5 kilos. NICU admission and in incubator for 3 days. Dynamic retinoscopy is normal. PGP is, no, I mean, there's no present glasses. Cycloplegic refraction is really normal. And there's presence of optic atrophy and MRI findings suggestive of HIE. Okay? So let's look at specific ocular parameters. Visual alertness. Child walked independently but had difficulty in cluttered environment. And when you look at the vision assessment with the Leia single optotype, it was 6/19, both eyes, and slightly better with binocularly, which is 6/15. Cover test did show a squint, which was a presenting complaint. There was a horizontal jerk nystagmus, probably because of the optic atrophy. Otherwise, eye movements were full. Leia puzzles, color, yes, black and white was also possible. And so basically seems to have some amount of orientation concept. If you looked at the Leia mailbox, horizontal was present, vertical was present, but oblique was absent. Contrast sensitivity, 2.5%, and visual field appears full. And contrast sensitivities, you could do it even with the hiding Heidi, as you saw earlier, Dr. Rath present. So overall observations was difficulty in crowded environments, poor pencil grip, difficulty in identifying orientation. So at this point, we use the VFCS scoring, which scores from level 1 to level 5, how the visual function is really used for this child. How is the functional vision for this child? So level 1 says uses visual function easily and successfully in vision related activities. No need for any environmental modifications. And to level 5 does not use visual function even in adapted environments. Okay. So if you look at the VFCA's grade and apply it for this child, and where you break it down into communication, orientation, mobility, task, etc., etc. Where does this child fall? Establishes eye contacts is a bit poor. Avoiding awareness of obstacles on the path to reach out to the target and person, also a bit poor. Other things were okay. Activities with sustained near task. Remember, we talked about both for playing and for writing, etc. All seemed okay. With the Leia puzzles, Leia near playing cards was all okay. And communication, orientation, mobility, and sustained near task. If you overall look, this was the score. Okay. So the recommendations were what you would typically offer for a child like this is in crowded environment, the child should be encouraged to look slowly, scan the surrounding, and then walk. Reading, advised to track the text with fingers. Leave more space between the words when the child writes. Cover the text that has been read with a card or back of the hand, a crowded text. So you can put a little card on top, and so the child is just focusing only on the line he's supposed to read. For eye-hand coordination, encourage to do activities like joining the dots, tracing, lacing the colorful beads, etc. Maintain a well-arranged environment to reduce the clutter. Can give additional verbal reminders and encourage them to do tasks to reduce distractions. And there is a need for occupational therapy to integrate sensory systems to support vision, to improve his attention and concentration, use extra lighting over the reading text so that there is no glare, to help with this near task. Okay, so there is more, but I think I will stop here. So it gives you an idea of how exactly do you test functional vision, and based on your findings, how you give recommendations. I know many of you are already experts in this area and probably preaching to the choir, but anyway, that's all I have to say to you, and thank you very much, and thank you for the opportunity.